So good afternoon, everyone. You're in the right place. Welcome along. This is our fourth QPS Talk Time of the year. It's the spring equinox today, so I hope everybody is feeling springy. John Brennan, good afternoon. You're very welcome.
Good afternoon, John Fitzsimons. It is wonderful to be here.
Thank you very much. Yeah, good to have you here. And we've lots of guests who we'll introduce now in a moment, but we're going to start off as we always do, kind of just running through the housekeeping. So it's a real pleasure. I must say thank you to John, who's helped us to assemble. I'm looking at, we really have covered north and south today, so it's a real pleasure to welcome John and our guests from the community. So Elaine, Harrington and Fiona McMorrow are joining us from Cork. Dr. Ahmeda Ali is up in Letterkenny, and Don Tyler is over in Wicklow. So we've covered north and south and east. We need to give a hat tip to the west, and I'm sure our audience will fill in the gap there. So we're going to really kind of let John direct the conversation to hear, some of the work that's going on in the community and what people are doing, and what makes the community different from the point of view of improving quality from maybe other contexts. So, John, I'm going to hand over to you.
Thanks very much, John. And as I said, it's wonderful to be here today and to have the opportunity to chat with all of you and to explore some of the intricacies and some of the challenges, some of the elements that are unique to and some of the most exciting bits of quality and quality improvement in the community. I'm particularly delighted to be joined by Elaine, Fiona, Ahmeda and Dawn, though, because they are improving quality where the rubber meets the road, as we say. They're incredibly dedicated and busy professionals who find time always to make improvement happen. And it's their insights I'm looking forward to hearing most from today. So we might start down south in Cork with Elaine and Fiona. If you guys would like to tell our audience today a little bit about your own context or where work happens for you guys.
Okay. Thanks, John. And look, thanks for inviting us here to this afternoon session. My name is Fiona McMorrow and I'm an occupational therapist, and this is my colleague Elaine Harrington. Both of us work in residential care services in Cork. So we're going to talk a little bit about our QI journey to date. I'm going to start first, and then I'm going to hand over to Elaine to talk about our current project. Our first QI project focused on promoting positive aging in long-term care, and it was a collaboration between physio, OT, the activities team and the residents. When we started our project, it was in the midst of the COVID pandemic, and we were acutely aware of the negative effects the COVID restrictions were having on residents' cognitive and physical well-being. And we know from evidence that physical activity and engagement in meaningful activity can support and maintain positive aging and well-being. So we took this QI opportunity to change the way we worked by using gardening as a novel way of incorporating physio and OT prescribed programs into the activities program. We had targeted interventions, focusing on the residents' physical, cognitive, social abilities and interests, and focusing on the principles of positive aging and the last 1,000 day philosophy helped us to have kind of shared values as a team, and this helped us to work better as a team. We were able to co-produce the piece of work with residents by using cognitive and communication strategies to optimize and support their engagement in the feedback and planning sessions. And using the QI methodology, we were able to do small tests of change record and monitor those results. The results were a success. We're continuing to offer blocks of activity to residents where residents attending can get up to 60 minutes physical activity per week. And I guess the striking thing to us as facilitators was that the residents really valued this piece of work, and they really valued the work aspect of the gardening, they've expressed a clear preference for this new way of working. I guess for us as health care and social care professionals, it's helped us, it's given us some insight into how residents are functioning, and that can help with our core functions, our core work skills. But most importantly, it's increased our awareness in the role that health and social care professionals can play in promoting positive ageing and well-being in this setting.
So that was our first trip as improvers, and it was exciting and interesting, but we didn't have the full team working with us at the time, which was a limitation. Imagine what we could achieve if we had everyone looking at delivering care through a QI and patient safety lens. And we knew to succeed with this, we needed to collaborate more with nursing and healthcare assistant staff here. Together, how could we make this a better, happier, safer place, promoting positive ageing for the residents, especially considering that this is where they're going to spend their last 1,000 days of their lives. So luckily, another opportunity arose for us to hone our QI skills with the RCPI Postgrad QI Leadership course. And again, this is a team approach, and this time we have a supportive Director of Nursing on board the team project with us. And now we're currently shining a light on trying to reduce falls and harmful falls for residents in this setting. And we are in the throes of this project right now, and it is great to have the wonderful expert guidance of the faculty and peers that are on the course with us, because our aim is to reduce falls, and we're using processes to achieve this, like trying to implement multifactorial falls risk assessments, multifactorial falls prevention plans, and we can see that to achieve this, we need to improve how we communicate as a team. So we're finding increased opportunities for on-the-job interprofessional education to listen to staff, design solutions together with our residents and their families. And people ask, how do we do this on top of regular work? And to be honest, it's become part of how we regularly work. QI is part of all our roles, but maybe in the past we didn't have the competencies developed to know how to do it well. Like, how many times have we all piloted something that seemed like a good idea, but we didn't have a robust set of outcomes, or we didn't do small tests of change first to see if it was really making the required difference? So this approach has helped us as a team to identify how we can prioritise our work differently, identify the residents with the greatest need and how we can assess them together. And it's providing insights into the different roles and skill sets involved in interprofessional working, especially in this residential care setting where it's not the norm to have health and social care professionals working as integral members of the team. And I guess above all else, utilising a QI approach ensures we must put our service users in the centre. We must design the service around what they want. And QI works best for the service user when it is done as a team. Like, we're all health scientists, we're working in healthcare, and I think this approach puts a real scientific structure on how we deliver care to optimise outcomes for the patients, and that in turn can add to job satisfaction. Because there is so much emphasis put on reducing waiting lists that it can appear that the value of care we're delivering is diluted sometimes. So the QI approach does need to be prioritised as a normal way of how we do work, but it is a skill set. And there's really helpful toolkits available on the HSE QPS website, but it's even better when there's a local champion to walk you through how to use them, or as in our case, apply for the HSE or CPI QI courses. But to succeed, you do need interest, you need help developing the skills and competencies, you need a good team to work with, and you need support from management to deliver care in this way. And I guess above all else, if you're wondering where to start or how to start, we say just start small.
Wow, Fiona and Elaine, a wonderful example, or examples of lots of different themes that I think are going to be really important to us today. That idea that you guys are working and improving in the context of home for the people you call residents, that they have to be at the centre of this, no matter what you're trying to work on, and how you've oriented your efforts around getting people more active around something that's going to be, energizing exciting and important and interesting for them. So I just think that sounds fantastic. You guys obviously then, are talking about, the skill sets that you've honed and developed by doing this work, by finding ways always to do a better best in applying QI methodology. And you're living that philosophy of, going to work to do your best every day, but always finding ways to improve that too. So very, very well done and wonderful work. Congratulations on it. And I'm looking forward to seeing how we can explore some of these themes further a little bit later on. Dawn, I want to bring you into the conversation here. First of all, apologies for the typo on the intro slide there. It is, of course, the wonderful Dawn Tyner as opposed to Dawn Tyler. So Dawn, you're very welcome today as well. Would you like to tell us, Dawn, a little bit about your work context and maybe some QI experiences that you've had?
Yeah, difficult act to follow there from Fiona and Elaine, but really exciting to hear because I suppose a lot of what we're doing hopefully might influence our community clients and then as they move on into residential care. So I think from our perspective, where we came from is working on a project with the GP lead. So I work as a community healthcare network manager in North Wicklow, originally in South Wicklow, one of the learning sites for this launch care implementation of the networks. And our GP lead was involved in the very early stages in this part of our quality improvement journey, although it's been building on work that's been ongoing across the disciplines within the community probably since about 2017. So I think really the first step that we talk about is how we packaged what we wanted to look at and then kind of defined, refined. Instead of thinking of, we went in a little bit ahead first thinking about solutions and went back to what's the actual problem. So what's our root cause analysis? So we were looking at client flow through the system, through the community services, client flow from the GP into our multidisciplinary team in primary care, which hopefully was the first port of call for many of our clients. And then that two-way communication, so the feedback to the GPs and bringing the GPs back into being part of our team. We hope they never left, but there was probably a perception there that we were all kind of gone on different routes for a little while. So it's been a huge opportunity for us to work as a team and bringing our colleagues in. So I think just listening to what Fiona and Elaine were saying, what was resonating there was just that piece about bringing back to the client. I think we started on the journey maybe thinking about our workload and how could we make things, but actually when we changed the focus to, and we spoke to our clients and spoke to service users that were accessing, we said, look, what's the main issue or what's kind of causing problems? And they just said access and communication. So then we looked at, right, well, how do we make that work for us? And then we looked into even kind of leveraging, harnessing communication, technology, data to really make that that difference. And so our piece that we worked on was about an electronic health referral pathway, building on the work that had happened during COVID and using the links that were already there with the GPs. So, yeah, I think the big piece for us was probably an opportunity presented it in terms of launch care and new developments and new teams and new roles. But actually, fundamentally, it's what we've been looking at for years, which was just client access and flow of communication. And then as both Elaine and Fiona mentioned, I suppose the opportunity for us maybe was to have the support of the project and the faculty there. And, as we went through the QI journey. But then what we've done afterwards is we've developed that peer support. We have our QI network. We have the opportunities that people know who has experience working in quality improvement. They can reach out, and it's not just us. There's much broader team there that have had the opportunity to try all of these tools. And as we talk about them, we talk about the menu rather than the toolkit. We talk about choosing from the menu, what's working today, what's going to work for us. We pick and choose. We might have 2 starters today and 1 main course or a couple of desserts. So that's the way. And then having that support network across our community health organisation and across the disciplines, across the teams, across the services into acute services now is our next step. But yeah, it's been a really positive experience so far.
And it's one, I think, Dawn, you're underselling a little bit there. I mean, knowing a little bit more about what you guys achieved in, totally redesigning these referral pathways, integrating specialties and ways of working that hadn't happened before, and how usage in your area has absolutely skyrocketed, and all the wonderful feedback you guys have gotten. I think there's a flag to wave on this one as being just a really wonderful example of how care can integrate between different professionals in the community around the needs of patients and people and clients. So another wonderful story, another wonderful example, and another kind of huge challenge taken on in bringing all these different people to the table, and designing and iterating and building a brighter and a better future for these referral pathways. So well done, and congratulations on work very well done, and work that I know is ongoing and improving all the time. Ahmeda, I'm delighted you're here with us today as well. I know you're dialing in from Letterkenny today. That's your work context today, but I know there's a few other contexts as well. So would you like to tell us a little bit about what work looks like for you at the moment, and again some QI experiences from the community?
Hi everyone, so my name is Ahmeda Ali and I'm a general practitioner. So I'm based in the northwest of the country at the moment, doing a few locum projects. But at the same time, I like to be involved with the RCPI QI faculty, where we facilitate sessions for trainees doing the HST courses. So quality improvement in practice in the community for me has involved undertaking a project where we try to improve the repeat prescribing process in a busy general practice setting. So our problem basically was that patients' prescriptions were not meeting our 48-hour target, where we were trying to process the repeat prescription requests. So our main goal was to improve the service to our patients by reducing the actual time wasted by our reception staff, so we could reach that 48-hour target, so patients could collect their prescriptions. So this involved our interprofessional team. We established this within our team of general practitioners, our receptionist staff, and our admin staff. And this was identified as one of our priority issues within the practice. So we met a few times, 4 in total, within a 3-month period, and we used our continuous quality improvement methodology, so including the PDSA cycle. Currently in this practice, we have 4 partners, and our repeat prescribing process is actually computerized. But what was happening was our receptionists felt that their workload was becoming increasingly unmanageable. And it led to a high cost to themselves, their mental health as well. So we undertook a questionnaire survey to see what they felt was their most unproductive and time-wasting task, and repeat prescribing appeared. So this was their most stressful, most frustrating activity, and they often had to wait in corridors to catch the GP or the doctor to sign the prescription whilst the patient is actually waiting at the reception desk. So we as a team, we agreed that this, we agreed to tackle that this is a matter of urgency. Time was being wasted, patients were complaining, and we had to get on top of this. So during our meetings, we used brainstorming techniques to structure our discussion, to talk about our experiences, and it was a fantastic opportunity to actually share our own experiences. And then what we did was, during the meetings, we created a high-level flowchart. So it illustrated the major steps of the process, and then we turned it to a top-down flowchart. So we looked at the actual activities which were undertaken across the practice, and we tried to obtain more knowledge about our current performance. So we had then done an audit over a month period, and we tried to assess how many prescriptions were ready for collection within 48 hours. And then we also tried to identify, is there a need to look at the medical records to be checked before they could be signed? So there was a few problems along the way, which we also discovered whilst we were trying to brainstorm together. We figured that another problem was there was a major cause of delay and uncertainty because the doctors which were within the practice, we were signing the prescriptions at the end of surgery. There were many distractions, telephone calls, limited access to computer screens. So we were under a lot of pressure to leave the building actually to start our house visits, for example. So repeat prescribing was slotted in between of all these extra tasks. So we found that was also a huge problem. So our key measures for improvement was, we wanted to reduce the turnaround time for repeat prescription requests, and we wanted to reduce the number of requests needed to look at the medical records to issue the script. So when we were brainstorming with our team, we came up with a few strategies for change. We wanted to give the signing of repeat prescriptions a higher priority. We brought them to the doctor's desks at an agreed time. We moved the site for printing the prescriptions to the reception desk so we could facilitate face-to-face queries. So with this project, after 6 months of implementing our changes, we studied the results, and thankfully we were able to undergo 2 further PDSA cycles. So we checked at 6 months, 12 months and 24 months. And once we had a look at the effects of these changes, we found that we could actually turn around the prescription times from 93% to about 99% within 48 hours. So this actually caused a ripple effect, which then led to receptionist staff, a lot less stressed, patients happier that they're receiving their prescriptions within a time period. And also what we found was, because we started these interventions, we also were able to actually reach a 24-hour turnaround time, which is fantastic, which we didn't actually expect. So it showed that the process was running more effectively and efficiently. Through our QI journey, we learned a few lessons. And one of the lessons and the weakness, I guess, within our project was we didn't have any formal measurements to record patients' complaints or that there was a significant reduction. So for us, this was one of the lessons that we learned, that next time when we do undergo a project, we need to make sure we have our patients on board and, to get their views and opinions of our current service. So there's a lot of learning, a lot of changes. And we were able to kind of, continue and maintain this project over a 2-year time period.
Wow, very, very, very well done. And, a wonderful illustration of how, you bring the team together, you start, studying the system in detail, pulling it and picking it apart, generating ideas together on how it might change. And then you put them into action and see what happens. And as you say, there were all these ripple effects and knock-on effects and new problems discovered and lots of learning along the way for everyone, and I'm sure that must have been an incredibly satisfying result to see at the end of it all for the whole team, because anyone working in general practice knows repeat prescribing is one of these really important and very risky jobs that we do all the time. And as you say, it often ends up on the bottom of the list of priorities when there's acutely ill people in front of you. So another example of trying to fix the airplane while you fly it, Ahmeda. Very, very, very well done. John Fitzsimons, I don't know what you think of our community QI showcase today. Are you seeing where QI is in the community?
Absolutely. I think we're left in no doubt, that QI is here, and I think it's everywhere, isn't it? And I think I think we haven't just found the deviance in the community here, John, have we? I think this is just representative of what's going on. I think.
Yeah, absolutely, John. I mean, I was involved in a bit of research just last year where we were looking at quality amongst GPs, just that group, just that cohort, a tiny group within the whole community context. And we were looking at the different ways that they assess and they measure and they think about quality. And there were an incredibly large number of variables, but none of them had been through a formal QI course of any description yet they were all reporting back, different elements that they use, how they measure and think about tracking change over time, how they test things on a daily basis to see if they work or result in improvement or not, how they think about things that go wrong and how they learn from that. Loads of these different kind of QI strands that are woven together all the time, every day, amongst all good healthcare professionals, while they keep, the whole thing on track, and they keep the work going, and they keep the patients, seen and looked after and cared for, and all the rest. So yeah, it seems to be happening everywhere all the time.
I mean, what struck me a lot in what everybody was talking about is so much about the people, and the importance of teams, and the interdisciplinary nature of obviously teams, interprofessional nature teams, the interprofessional nature of the work, that seems to be a huge element of this. And then I think that's also reflected into, and I love, again, Elaine and Fiona's project around the using gardening. It's just such a person-centered way of getting, to really what matters to people. And I think having the courage to be able to propose ideas like that, but believing, in yourselves to do that is fantastic. But relationships seem to me to be key here across the community. I don't know what folks think about that.
Well, I suppose Fiona and I are really lucky, I think, to be able to work with each other, and we work really well together. And we bring, like, from the different disciplines, coming together, we can learn from each other, and we can be really honest with each other as well. But you're right, I think having that person-centered and just always trying to know what's our role and how can we make things better for the service users, or, like we say, our residents, that definitely helps. But definitely having somebody to do it with and having a team to do it with helps.
And I may add as well, I guess that means also having respect for the other person's profession, and acknowledging the expertise that they bring to the team, but also being comfortable to work interdisciplinary. And I think over the last couple of years, we see that a lot more in our setting here, a lot more interdisciplinary working, working together where we're looking at the user and the best interest for the user. So all those things have helped us here in this setting.
Yeah, I suppose the different perspectives our disciplines bring, and allow us to bring. Ahmeda, you wanted to come in there?
Yes, I just wanted to add, I honestly believe that we're really privileged being in the community, because we're able to talk to our patients as well as their families. So it allows us to undertake QI projects, and it allows us to look at their patients, their families, and we can get them involved and take that opportunity to allow them to get involved to shape and test the services that they actually use. So it allows us to provide higher quality and more consistent care. So it's all about using what we have and using the skill set that we have and being able to kind of branch out with it. So I just wanted to add that in, that it allows us to have that continuity of care.
Yeah, and it's really kind of taking, patients and families and, as an asset in terms of being there to help co-create their, the care they need. And, maybe we don't, get the opportunity to do as much of that as we'd like to in the hospital system, but I think we're the longer term, and I suppose, again, relationships happen over a longer term, perhaps, that allows that to happen.
Yeah, I think, John, as well, the relationships are built in different ways at different times as well. We'll have, certainly in general practice, lots of short interactions over very long periods of time, with people and their families and other members of their community. The context that's built is slightly different. And through those interactions, we get and we create and we make a different kind of safety where, people have conversations, I think truly and really more often about what really matters to them, what really bothers them, what really worries them. And I think, you can often get closer with individual patients to a higher level of co-design and co-production around their individual health needs, which is incredibly exciting. And you know, in comparison to the hospital setting, where people are often in a more vulnerable state based on how ill they may be, or you know, how out of familiar territory they may be, or whatever. You know, as Ahmeda said, I think it's something to appreciate, and something that we're really still only scratching the surface on, in terms of, you know, the wealth of ability that people have out there to lead on their own health, and to lead changes for health within their own communities around Ireland. That's something to be supported and boosted.
Great. Dawn, you know, one of the things I think that underpins quality improvement is data, you know, and is that different in the community, and where it is and how you get it and how you use it?
Yeah, I think we talk about data and we get well, I know I get a bit nervous, and I have to say numbers was never my strong point. But actually working with it, and I think really for us, one of the key pieces that we found was not to be afraid of the data, and then painting a picture with it, telling the story. So we were kind of looking at it from the qualitative and quantitative side, and we realized we were very good on the qualitative, and we needed to bring the quantity in to really sell what we were doing, and to actually give an opportunity to spread. You know, when you do quality improvement, you're looking at your population, you're looking at your colleagues, you're looking at your clients, but actually everything we do should be scalable, it should be spreadable, it should be replicable. And that's where we brought in the data piece. Now it's not without its drawbacks, in terms of, you know, we've had challenges in terms of, we would have thought that the project that we had done was an opportunity to be used on a much wider platform, but that hasn't happened as yet. And you know, we're still working on that. So sometimes, you know, even with all of the data, there's different barriers that you come up against, whether it is from an ICT perspective. I suppose we're thinking ahead to this integrated client management system, you know, an ICCMS that works across all our unique health identifiers. We're kind of preparing ourselves. But a lot of what we've done has given that front end of that pathway and that opportunity. It's given it a home, it's given it a package, but we haven't really managed to move it as far as we had hoped we would as yet. But we're hoping that by continuing with the work that we have, continuing to gather the data, we have it available, that when the time is right, we'll be there then to support that next step. But just even touching on what the others had said, just about the relationships, and I think the one thing in particular that we found, like when we talk about the journey that we've been on just around this project, and there's 7 or 8 projects have spawned from what was one small project. It's about sustaining yourself. It's about sustaining your colleagues throughout that, because it can be very easy sometimes when we do come up against the barriers. And I think the relationships is what really pushes everybody on, and it's bringing it back to the client at the center of the process and the pathway. And that's the only way that we've been able to sustain what we're doing when we have come up against challenges. So how do we kind of adapt? How do we innovate? How do we change direction if it's not working for us? And that's only by using that experience across the whole team and looking to say, right, how will we keep this going? And there are times when your energy peaks and flows through it, but yeah.
And I think that's coming through as well, isn't it? It's obviously it's for patients and families and clients, but also it's using that interdisciplinary perspective to help each other's work, you know, and not just having respect, but also, you know, what can you do to help, you know, somebody else's work, or make somebody else's work easier to do or more effective. John, I'm interested, you know, like we know lots of quality improvement is happening in the community. So what's the advantage of let's say, taking a QI approach, or asking people to think about using QI methodology then, if it's happening anyway?
Yeah, I mean, like I think one of the advantages, John, is that we all only have so much energy. We all only have so much goodwill. We all only have so much headspace. And when we're trying to put it to this great use, we want to make sure we are as effective as we can be. If we're going to put energy into this to try and change things and improve things, we want to get the maximum bang for our buck. And we also want to do that as efficiently as we can in terms of, you know, the energy we spend on it. Because, I mean, you listen to Elaine, Fiona, Dawn, Ahmeda. I mean, there's so much more improvement that needs to happen. You know, we all want to do that. We all want to be part of that. So we want to improve efficiently. We don't want to be wasting energy and effort on the fringes or the edges in the things we're trying to adjust or change. We want efficiency and effectiveness. And in that sense, I think that's where quality improvement methodology, learned structured approaches can be really useful in sharpening that and in directing that energy and effort to the best effect. I think there was an interesting point made as well. I can't remember who raised it around, once you start to dabble in these PDSA cycles and word gets around, you will all of a sudden realize that although you're not in one big hospital building, maybe with a QPS lead who has a door at the end of the corridor to connect people, even though you're not in that sort of setting, there are people scattered out there all over the place, with similar skill sets. And I think where we can join those dots up and we can connect, then there are opportunities to achieve things at even bigger scale and to spread and sustain initiatives, as Dawn was saying. So, I think there's a power as well in adopting certain approaches and telling people about it, because, they're recognizable as a badge or as a way of other people understanding, okay, this is what you're up to. Let's see how we can connect and maybe build a network and some scale around.
And I think the methodology, I suppose, gives a shared language as well. And we realize that a good idea may be a good idea in one place, but it probably can't just be lifted and dropped into somewhere else. It has to be slightly adapted, and that's where the tools are really helpful. At looking at that kind of small test to change. Ahmeda, have you found that?
Yes, so I also found some challenges as well. Challenges in terms of trying to undertake and start a QI project. Especially, will it work? How can I convince my colleagues that there is a solution? And but what I found useful throughout the QI journey is to learn to be prepared with clear facts, figures. And this helps us convince our other colleagues, that these measures of impact that will happen and are able to kind of demonstrate their advantages of the solution. So I do find that quite useful. And sometimes, what happens is that these interventions that we undergo, they may lack sufficient evidence. So being able to kind of deliver good results, and it's seen as a motivational incentive as well, to improve patient care as well as save time, avoid kind of wastage of resources and time. And especially in the community at the moment, it's really difficult to recruit general practitioners and other multidisciplinary team professionals like OT, speech and language, etc. So it's all about trying to use our resources as wisely as possible.
Great. And even Fiona and Elaine, even your very person-centered approach still benefited from you doing those small tests of change, didn't it?
Yes. I guess just following on the last comment, and just seeing what's in the chat box, we definitely have found, we always have students here on placement here, and we have found them a great resource in terms of helping with projects and helping with, gathering data. And, so definitely that comment in the chat box, I couldn't agree more with, John.
Especially as Fiona and I are, I'm the sole physiotherapist, she's the sole occupational therapist in this setting. So, there isn't anyone else to do the work while we're doing this work. So, we just have to figure out a way of fitting it into work and making it kind of how we work. Yeah,
it's great. It gives the students an opportunity to see the value of these kind of approaches as well. And
but without the PDSA cycles, you can definitely get overwhelmed or kind of be going down the wrong road and kind of go, why isn't it working? And then it's like, if you don't take the step back and actually, look at what you think is going to happen and then see, they do help, otherwise you don't maybe stop, you just plow ahead and, you can't even show what's working, what's working.
That's a nice point. You know, I mean, that you know, one patient or one day is small enough, you know, to test something or try something out. Sorry, Fiona.
Oh, sorry, John. Just that was our biggest learning with our first QI project, was the value of those kind of small tests of change and taking the time to do that and to learn from those kind of PDSA cycles. So really, really important. And then just homing in on that the QI is part of our practice. You know, it has to become part of our, embed into our own kind of daily work practices.
John, just coming in there in terms of the chat, and a few people have touched on it a little bit in terms of the value of the relationships. There was a question specifically for Dawn, just in terms of actions they took in Wicklow to streamline access and improve communication, but also, and probably more particularly, the specifics around building the interdisciplinary working. And I think that's something that's probably relevant for all of the panels in terms of, I know some of you probably had a good relationship anyway and work really well together, but where you're connecting them with other disciplines, what made the difference? What made it work?
Yeah, I think the piece maybe was we started with one discipline and we moved. So we we tested it per discipline, and then we learned and we adapted based on the needs of whether it was either whether it was on the needs of the client population being referred or the discipline themselves. And also because we had an opportunity to feed back the information, say, around waiting times, around referral criteria, we were streamlining all of that information and building the relationship with our colleagues, our GP colleagues in particular, was where we focused initially. As we said, the next step is looking at acute services. We haven't quite got there yet, but it was building staff directories, service directories, referral information, sharing, like being very transparent about, information that we were sharing with everybody, with all of our referrers. So I know our focus initially was, GP into primary care and back out. But the next part of the puzzle is the integration. And we do have opportunities, like we're building on, there's some really interesting work happening between our networks and Vincent's, just around, say, an osteoarthritis knee pathway. So we can use the connections we make there into the acute services then to start to build and to spread. So it is the one piece I think as well, we talk about, like, we can make changes in a day, but some of the changes take a lot longer. And I think that's the one piece as well we've had to learn a little bit, that some of our outcomes were unrealistic to begin with. And also I thought we would be much further on, possibly with some of the further integration into our acute partners. So I think that's another piece that we learned along the way, just adjusting timelines but using opportunities then as they arise through other projects and other paths to see, can we build. But I definitely think having our GP colleagues on board, having the shared MDT learning then from, sharing this project and saying, look, this worked for this discipline, but we had to adapt for another discipline, and then feeding into our multidisciplinary team meetings as well, which were reestablished, and having that platform as well to learn across the disciplines and to learn from specific clients, but also client cohorts as well.
Yeah, I think that's really helpful. It's funny you talked about staff sort of directories. I remember when I started out working, it was at the Southeastern Health Board. It's quite some time ago. But one of the things that they had at the time was a staff directory with every single head of discipline, and you knew where to go to get a decision or to get information. And it's hugely helpful when you're trying to do work like this across communities, and you may not necessarily know who the relevant person is or how to contact them to begin with. I think if you can get those basics, then some of the other pieces are much easier. But thank you for
and
that.
one other piece, I suppose, that we have to reference when we talk about quality improvement in the community is the role of our project management office. I think that's quite a vital role. That's something that's only really in place like since mid-2018, and having that there as well to package, to raise the profile, to share again, across. I think there's a huge opportunity there. And now the restructuring of our quality, what do they call it now? QPS in the community is quality, safety and service improvement. Even the reframing of that name, I think, has really helped us. There are and the new roles that have come into our QSSI department, and again the relationships, but just starting to expand and recognise the role of quality improvement alongside the safety piece, I think, has been vital for us.
That's really good. Thank you for that. There is another question here, and it's probably for the broader panel in terms of people's own experiences. And it's about what happens if staff move on. And from a project sustaining perspective, very often a lot of these projects rely on the passion of a small group of people. But what do you do if people move? And have people any thoughts or experience around that?
Yeah, I might come in on that, Juanita. I mean, I think it's a challenge for us all, isn't it? Across the whole healthcare system, and people do move, vertically, horizontally, exiting the system, entering the system. I mean, I think again, within good QI methodology and planning, especially when you've done it before and you're looking to the next project or the next initiative or the next effort, one of the first things you start to plan is, okay, how do I do myself out of a job here? How do I make sure this is not all falling back on one person for forevermore? And I think that's something that comes to a degree or to an extent with experience. The other kind of piece that I've picked up from work done previously is that if you can continue to grow it and scale it and spread it and talk about it, it's more likely to continue to live on. Because these are good stories, these are positive stories and positive experiences, and very positive groups of people who get together and get excited and get energized, as people have said already, about making a difference. I think that attracts an energy. So even if one person, for whatever reason, does move on, there's often going to be other people ready to move in and throw a shoulder to the wheel as well. Once they get a glimpse of what it is that you're up to with this quality improvement stuff.
Yeah, and I think definitely in the quality improvement world, a lot of people are very much doers. So they're getting on with the work. You're doing the work as quickly as you can because you're under pressure with pieces, and we don't take the time to necessarily share it as much as we should. But it is fundamental to helping something sustain. So there's something powerful in it. There's one final question, and then I'll pass back to John, and it's, where did people access funding for their projects? Maybe that's something people don't want to talk about, but I don't know if you have any thoughts on that or anything you'd like to share.
There was no direct cost involved in ours. It was within existing resources. Now, we did have the opportunity to access the quality improvement program through RCPI, but that was the only piece. That was from our perspective.
Same for us. The HSE sponsored the RCPI courses, so we just keep an eye on when they come up. And then, no additional cost for the projects.
It's brilliant.
On that, maybe
we did need we did need families to donate for our gardening project. We didn't have any resources for the actual tools and equipment and plants, but families were very happy to get involved in that point as well.
It's wonderful.
I was just thinking of people having the opportunity to plan ahead, because, this comes up as a multidisciplinary opportunity. A lot of the time it's a team of 3 or, and just maybe go and talk to your colleagues and see, would you have an idea, or is there 2 or 3 of you that are interested? And then when it comes, you can express that interest then when it comes back up.
I think that's a great plug for the diploma, John. There, you can maybe talk about the prospectus next. I don't think we're going to get better than that. I'll pass over to you again, John. There, thanks very much, everyone.
Yeah, great discussions there, guys, and lots of lovely comments, lots of compliments to all our speakers here today and all the great work they've been doing and involved in, and wishing people well and hoping, to see it shared. And obviously today is one of those opportunities, but, maybe to kind of finish on that, John, this seems like, as we move towards Launcher Care taking a bigger kind of influence in the community, quality improvement needs to be part of how Launcher Care is going to, do its business, isn't it?
I absolutely think so, John. And I think if there's kind of a key message coming out of today, and even from the questions and comments that are coming in, it's this spark around sharing. We need to share these problems. We need to share all of these multidisciplinary and context-specific perspectives, and we need to share aims. And where that spark exists, as we'll always say, then the next bit is that it's easier to seek forgiveness than it is permission sometimes. times. When you have an idea, start to germinate it, make a connection. Don't shy away from pitching an idea, from finding a first follower, and from testing an idea, and it can always grow from there.
Yeah, super. And I think, it's coming out very strongly in the last bit of discussion there, the importance of linking kind of, the goals of the system overall with the work of people at the front line. And I think we need that, harmony there, don't we? John, I think you put together a few resources for us, just for people in terms of tools and some maybe resources that people might be.
Yeah, we can share the resources after, John. But I think to come back just on the resources, even a key point that Dawn made earlier, I mean, they're a menu. Choose the tool to fit the problem. Don't make the problems fit the tools. Would be the key message around the resources. So there's a variety there for people to explore different ways of thinking about QI in the community context, and as we said, the importance of starting to integrate these different ideas, approaches, and people.
Fantastic. Well, look, that's a good place to end there. Thank you to all our guests for joining us. Thank you, Ahmeda. Thank you, John. Thank you, Fiona and Elaine, and John Brennan. Thank you very much. We look forward to hearing from the community again soon, and all the good things that are happening there. So just a quick kind of couple of mentions here. The Quality and Patient Safety Prospectus, the QR code there will bring it to you. So that's again a great collection of resources for many of the things we've been talking about there. Like John said, it's a menu. So you're not going to need to use everything in the prospectus, but it's finding the tools and the approaches that you want to use, and maybe to try something for a particular time and see if it helps you in your work. And I advise people just to explore, see what's there and available for free. And so one of the programs that we're kind of working on is our human factors learning program. So there is a short HSE Land module on an introduction to human factors, and then soon we'll have a foundation human factors one-day workshop for teams. So watch that space, and if you want to email us there at qps.education at hse.ie, you can get more information on that, and that will be coming soon. And again, just to make people aware of Patient Safety Together, again, another site where there's lots of resources on safety alerts and patient safety supplements. So important information to keep everybody safe. And then patient safety stories included there as well. Just a plug for the map again, QPS Ireland Network Map. Please get yourself on the map. And if you're on the map, ask a friend who you think might be interested to get on the map. And I think if we can do this, we can kind of really connect everybody, a bit like Juanita and Dawn were saying there, that's really an important part of this work, is to know where people are and what they're doing. And equally to think about joining Q and get involved in the Q community across Northern Ireland and the rest of the UK. That may be something, again, that you kind of can connect with people who are doing similar work, including in the community. And then finally, in 10 or 9 days' time, we will be at there's a workshop in the Department of Health where the board of ISQua will be attending. So we're going to get a chance to talk to some of the people at that, including Professor Jeffrey Braithwaite and Dr. Elorio, and Orla Healy and Rachel Kenna will be joining us as well, to give some thoughts on some of the discussions from that meeting. So I think that'll be very lively discussion, and I think we really get to tap into some world expertise there. So I'd ask you to join that. Just to be aware, it's on a Thursday, so it's not at our usual Tuesday slot. And again, connect with us there on Twitter, and if you missed any of the QPS Talk Times, you can pick them up on the on our YouTube channel. And that's it. So again, thanks to Juanita and Maureen and Shima and Chris, all in the background doing all the hard work. A big thanks to all our guests today and to John. And please do give us your feedback on the survey at the end, and we will use that. And we look forward to seeing you on Thursday, the 30th of March.